These webinars are facilitated by Healthcare Improvement Scotland in collaboration with Scottish Government, RCGP and NES. In this series of webinars, we cover a range of topics that are relevant to primary care. Today's topic is mental health and the primary care multidisciplinary team. Improving mental health is a priority and focus of national strategy in Scotland. Improving mental health multidisciplinary team capacity in primary care is crucial for the development and sustainability of new ways of delivering continued high-quality services to patients. Next slide. Before we begin, we have some basic virtual housekeeping to ensure you get the most from the webinar. To minimize noise interference and maintain streaming quality during the session, we have muted your mic and turned off your cameras. We would like to encourage conversations and would like to ask everybody to use the chat box to contribute. As the chat box can get very busy, one tip is to allow you to directly reply to a comment. Use the reply function. Please feel free to use emojis and reply function for communicating with others in the chat box as well. There is also an option to turn on closed captions at your end. Select the three dots for more options and then choose Turn on Live Captions. You'll then receive a notification showing your set languages. Specific instructions to turn on the caption is in the chat box. If you're experiencing any technical issues, please let us know in the chat box so we can help resolve it. This webinar is recorded and will be published on our web pages. A link will be shared so that those who are unable to join us today can listen into the session. The chat box is not recorded. The purpose of our webinars have remained consistent since 2020. They are a platform where we can explore what changes we have made and what we need to make as we move forward. It is also a space to connect and learn from each other. This webinar will be split into two sessions. The first session will be led by Michelle Ward, and the second session will be led by Scott Jameson. In session 1, we have speakers talking about the national perspective of mental health MDT working in primary care. And in session 2, we have speakers talking about examples of mental health MDT working. As we only have an hour today, we will be highlighting a very small sample of the topic of mental health and the primary care MDT. Without further ado, I am going to hand over to Michelle Ward, who is our facilitator for the first session. Michelle, you can try now.
Can you hear me now?
Yeah.
Oh, that's brilliant. Thanks, guys. Sorry, must have been a wee glitch in the machine there. Welcome, everybody. It's fantastic to see you all to number 12. Can't believe how much time has passed. Really important topic today, and great to see so many of you joining us. We know really mental health is the most common reason that people visit their GP, and across Scotland it accounts for about a third of all our consultations in general practice. That's about 8 million consults every year. And we know that mental health is an integral part of general practice, not just on the consultation front. And we've worked closely, as general practice and mental health teams for years together. And perhaps we were the forerunner of today's contract in MDT, thinking back to pre-2018, and many of us will fondly remember working really closely with embedded counselling services, and of course today as we work really closely with our local community mental health teams as well. Our first session today is going to take a kind of bigger picture view, and then in the second part we're going to move into the more detailed practice side of things. But today, just to show the breadth and importance of mental health, we've got presentations from a psychiatrist, from a patient partner, and from a GP who's also working to support workforce. So I'm absolutely delighted to welcome our first speaker, Alistair Cook, who is a psychiatrist and currently works as a principal medical officer in Scottish Government. So without further ado, Alistair, I'm keen to hear what you have to say around MDT working in primary care. Thank you.
Sorry about that. Didn't realise that I had to put my own camera on and mic on. So thank you very much, Michelle. Thanks for the intro. I just noticed on the holding slide there that you got me down as a PhD, which is a promotion that I wasn't expecting. But thank you for that. Where I was going to start was really thinking about I mean, Michelle's talked a little bit about the joint working that there has been between primary care, general practice, and mental health. And really over the last decades, we've seen a massive increase in the recognition and understanding of the levels of mental health and well-being issues within our populations. I mean, I remember back to Defeat Depression campaigns run by the College of Psychiatrists and College of GPs together in the 1990s. And in the last decade, what we've seen primarily has been a focus in terms of policy on access, and particularly access to child and adolescent mental health services and psychological therapies, and a pattern of increasing resourcing of those secondary care services with a rising demand which has consistently outstripped our ability to invest in those services. So we've never actually met the access targets that have been set consistently within these areas. In 2020, I came into this post having come from a health and social care partnership, and having had some involvement in work around the Primary Care Improvement Fund process, and really with a sense that there was a big gap. Michelle mentioned that we think a third, and in some surveys 40% of GP consultations have a mental health component. Yet the capacity within general practice to manage and support those with mental health and well-being issues that probably didn't require the input from secondary care specialist mental health services was quite limited. And we were aware of many examples through primary care improvement funding where we'd seen expansion of primary care multidisciplinary teams. And we'll hear about some of those examples later on. So in 2020, we set out and we had a short life working group with multiple stakeholders, which looked at an agreed model of how we might plan to do this. And I think initially set out with a huge optimism because there appeared to be a commitment to look to both fund that and then to look to identify how we might do it in terms of how we might implement this in terms of finding the staff who would be required to do that, recognizing that there are shortages across many of the disciplines that would be required. The ability to resource this, despite political commitment to do so, has proven difficult in the post-pandemic world. And while we're still holding out the hope that in due course we will see both funding and be able to develop a staffing model for this, at the moment we're very much focusing on how we work with the developments that have already taken place, learn from those, and then when we do get to the point where we can begin to identify additional funding, that we should be in the best place possible to really begin to expand the multidisciplinary team model. I think there's a recognition that it's the right way forward, but actually implementing is proving difficult. Just quickly in my last minute, I was just going to mention the staffing issues, because many of the models that we'll hear about today involve psychologists, occupational therapists, the community psychiatric nurses, and their involvement in the MDTs around primary care. But that we'll also hear hopefully about peer support workers and other potential groups who can, I think, provide a massive support in this area. And so we shouldn't necessarily always be thinking that this isn't doable because we have shortages within the trained professions, and we should be building up our capacity in all sorts of different and innovative ways in the general practice MDT. I think that's probably me used my time, so it's a short talk for me, and I'll hand back to you, Michelle, to introduce Gordon.
Brilliant. Thanks, Alistair, and a really helpful kind of start to set the scene for today's discussion. I think it's also incredibly important we hear the voice of the people who use our services and the quality of experience that they have. So I'm absolutely delighted to introduce Gordon Johnson, who is a public partner working with Healthcare Improvement Scotland, to talk about what works well for patients, what could be even better, and where the service might go in the future. So again, without further ado, Gordon, I'm delighted to welcome you to our session, and thank you so much for joining us today.
Thank you so much, Michelle. So speaking from a patient perspective, I guess the first thing to think about is terminology, because no one out there in the real world accesses primary care services, do they? They go to the doctors. And I think that in itself, that simple terminology leads us to some of the culture change issues around moving to thinking about multidisciplinary teams, because people think about the doctor and support staff rather than necessarily multidisciplinary teams. And I heard a story not so long ago from someone who works within the system, whose partner has asthma, and he had phoned up to make an appointment to see his GP, but instead was directed to a specialist asthma nurse. And his reaction to that was one of disappointment. And when challenged, he said that intellectually he understood he was seeing a specialist rather than a generalist, which was a good thing, but that it still felt a little disappointing to be seeing a nurse rather than a doctor. And I say this without meaning any disrespect to any of the brilliant nurses on the call. There is still a perception out there that the doctor is top of the tree and seeing a nurse is something of a lesser service. So I think there is an element of culture change that we need there to introduce to people the notion that there are a whole range of very qualified, very capable staff they can see. The other issue that people tell us very often is an issue in mental health is the triage system. Simply the fact that they phone up expecting to make an appointment. It can be difficult, we know, to ask for help in the mental health world. They speak to a receptionist who then asks them questions. Now, right away, there's a feeling of why is someone who's not a medical professional asking me questions? And that's even more of an issue in small and rural communities when people know that that receptionist might be someone they know or someone from within their community. So sometimes that can be a barrier in itself. We've heard that a third of GP appointments at least are to do with mental health. Flipping that the other way around from a patient perspective, what it means is that most mental health conditions are managed within primary care by GPs, by those staff in practices. So while we often think primarily about specialist mental health services, actually GPs are providing such a crucial service for so many people who are either not seeing specialists, waiting to see specialists, or far too often have fallen between the gaps in what is an increasingly complex system. So thinking on the positive side, what works well? Well, there's a few things that we're always told work well. And, although sometimes people think seeing a nurse rather than a doctor feels a bit like a downgrade, actually feedback we have from people who see mental health nurses in general practice is that the service is great. The nurses quite often have more time to talk to people than the GP does with their busy schedule. And actually the service can be very helpful for people. The other things that are talked about quite often in terms of what works are link workers. We know that ability to refer on to peer support groups to self-help groups to third sector provision can be very useful. And as Alistair mentioned, peer support workers can provide a very different type of support from that personal experience. So what might work better? Well, very simply, I think more services in primary care. People want quicker access to therapies, perhaps psychologists and doctor surgeries, why not? We have access to digital services, to CBT, for example, and that's great for people who use and like digital, but we must always remember not everyone has that option. There is still a digital divide, and up to 40% of people with severe mental health conditions can't or don't use digital services. So we need to make sure that's there. The other issue that's quite often around is the issue of CAMHS referrals. We know that an awful lot of CAMHS referrals come back, anywhere between 20 and 40%, as inappropriate. Now, making the assumption that those judgments are correct, that makes me think, okay, rather than referring people on and waiting for a referral to come back, how can we look at providing those young people with more of an immediate service within primary care, rather than always having to refer on to specialist services? Again, in a tiered model, that would leave those specialists to deal with a smaller number of more severe cases. And I think that would be a better service all round. Finally, I think the issue that people talk about most when we're talking about GPs is the issue of accessing appointments and the telephone system. I think probably many of us will have had the experience of phoning up at 8 or 8:30 in the morning and having to phone tens, dozens of times before we finally get through to someone. I can't help thinking that in the digital age, there must be a better way of doing that. Are there ways we can use digital or online to reduce some of that demand so that making an appointment can be easier? Finally, I think patient feedback is always welcome. Some GPs' practices are great at this. They have regular committees, they have regular surveys, etc. Others perhaps have some catching up to do, let's say. So, as always, a plea, simply talk to patients. If you want to know what patients like, what patients value, what patients would like to see different, the easiest way is simply to ask them. So from a patient perspective, I think moves towards multidisciplinary teams is a really good development, but it will take time to embed that. It will need the funding Alistair talked about. And crucially, I think it will need good communications to get the public up to speed with what we're doing and to make sure everyone is aware of exactly what the system can do for them. Thank you.
Brilliant, Gordon. Thank you. Lots we could be discussing there, and it's there's so much to pack in an hour, but we're running well to time, so I'm hoping we'll have some time for discussion as well afterwards. But some themes certainly arising about integration of teams and closer working. I think we're all agreed on that. It's just how we can do it, particularly when access is only through one portal at the moment, and that's through the GP surgery. We're going to have to get better if we want to have a broader range of services that are available for people so they can access the right person first time without having to necessarily go through general practice. But how do we do that in such a way that ensures continuity of care, which is absolutely vital if we're to provide good quality services over time to our registered populations, and do it in a way that responds to our local population needs. Whilst we're busy looking after other people, though, I think it's incredibly important that we take a moment to think about how we look after ourselves. And I'm delighted to welcome Dr. Kirsten Woolley, who's a GP colleague who is working in Edinburgh at the moment on the front line of things, but is also doing a huge power of amazing work in our National Wellbeing Service, and you thought it was incredibly important just to have a small section today, at least, just to think about how we look after ourselves. So, Kirsten, over to you.
Thank you. I'm really not sure if I'm in charge of my camera or my video or my mic at this point. So anyways, I hope you can all hear me now at least.
All good.
Yeah, all good, great. Really delighted to be here and have these 5 minutes to just tell you about the Workforce Specialist Service. So we'll just crack on into that, because on to the next slide. I don't know if I'm, yes, thank you. So whilst I'm going to tell you more specifically about the Workforce Specialist Service, I just wanted to highlight the range of offers that are available to all of you as healthcare providers. So, and as we've heard, we see a lot of patients with mental health difficulties, but this also affects ourselves. So the National Wellbeing Hub, I really encourage you to have a look at. That's the online resource, and everything on this page and that I mentioned is accessed through it. And there's a whole range of things, from webinars, materials for managers, quality assured apps, all sorts of things. And you can link through to the coaching offer and also to the local psychological therapies that are provided and available to everyone working in primary care, although they're delivered through the boards. But if you click on the map icon, then you can access what's local to you. And also just to highlight that there's a dedicated helpline number for health and social care staff, all hours of the day, all days of the year, provided through NHS 24, who have trained practitioners to receive your call if you should need to call at any time of day. But the Workforce Specialist Service that I'm here to speak about is also accessed through the hub. We can move on to the next slide, thanks. And as we were saying, we're invited to consider our own mental health needs. So the literature shows that whilst doctors experience good physical health, GPs in particular are noted for experiencing poor emotional and psychological health. The prevalence of anxiety and depression is higher in ourselves as a professional group, and although difficult to measure, what has been demonstrated is relatively high incidences of addiction, with alcohol being the leading type. And also female doctors and nurses are up to 5 times greater risk of suicide than the general public. So with that in mind, if we move on to the next slide, with that increased need, there's also increased complexity around our mental health. And part of that is a cultural issue with stigma, and it's been demonstrated through round group work, through significant event and inquiries that have taken place, that the stigma exists on 3 levels. So we stigmatise ourselves when we become unwell, we stigmatise one another, and there are institutional barriers to us receiving care as well. And so confidentiality is the leading reason why people have accessed the Workforce Specialist Service, which offers an alternative pathway that really allows people to achieve that parity of confidentiality, which we know is crucial to having and maintaining a therapeutic relationship. But also the service providers have training and experience in that specialism, which is to treat people who are used to being care providers when they become unwell, which can influence and affect the way that we present, and understanding the nuances and the complexity around being someone who cares for others and being regulated, and when your illness may or may not have impacts for you in terms of your professional status and your work. There are special arrangements with the way that they communicate with the regulators. So if there are issues related to your professional standing, that you can get that support and get yourself into a healthier position before having to go through any of those regulatory processes. We'll move on to the next slide. So the Workforce Specialist Service, like I said, is accessed through the hub, and the easiest way to find it is just to put WSS into the search tool at the top right. This is just a screenshot from my laptop, but at the top part of this page is my face. So now that you've seen that, it'll be also recognisable. But it describes for you what the service is, and that it's delivered currently by Practitioner Health, who have had over about 15 years of experience of treating doctors primarily, but now a wider practitioner cohort. Since the service started in January of 2021, we've had over 1,000 registrations from across health and social care colleagues, and 25% of those have been from GPs. So they've assessed and treated about 12.5% of our GP workforce in Scotland alone. But the forms to register are accessed through this page, but also if you're not well enough to do that, you can have your registration supported by emailing or calling them. If you, last slide, thank you. So we can make available the poster that I highlighted on the first slide, so that you can have all of the resources, but also the links kept to hand, or you could share it with your colleagues at work. And just, yeah, thank you for your time.
Fantastic. Thank you so much, Kirsten. And you'll see, as you've been talking there, and we've been posting some things up in the chat bar as well. Please, everybody that's on this call today, just take a moment to just copy and paste that, stick it somewhere. You never know when it might be helpful. And always feel free to pass it on to any colleagues and use it. It's there for us, developed by us, and is incredibly important. So some really interesting things starting to come out there, and what is really heartening is to hear the wish for closer integration and working together around really expanding that multidisciplinary team into primary and community care is very much the ethos and the direction that's set out in the mental health and wellbeing strategy. So that's good to know. Also recognising from you that mental health is such a diverse topic and so many different types of presentation, often linked into other chronic health conditions, often linked into wider society and issues that are happening elsewhere in a person's life outside of health. All of that makes for often what can be very complex consultations, and the importance of having people quickly at the end of a phone line or a digital link or a referral process to really help support us support people through what's often some of the worst times of their lives. So great to hear some of that coming. Some questions in the chat bar. Alistair, one area that I think pops up from time to time, and I'm sure you'll agree with me here, the importance of making good, high quality referrals between clinicians and members of that wider MDT, and really breaking down these very traditional unhelpful barriers of it has to be GP to consultant. We work in a much bigger extended multidisciplinary team now, and is that something that you're coming across from a specialist service, and what can we do about it if so?
Yeah, we're certainly coming across it, and I think sometimes it's a source of tension and conflict within areas, because it feels as though, I think from the GP perspective, that CMHTs are rejecting more referrals or sending more things back, and for me, the potential of an expansion of a multidisciplinary team and close working between that team and the CMHT would allow that to become a much smoother process. And that, I mean, I remember as a trainee, one of the things was that we used to go out and do our clinics in practices, and that didn't, okay, while that was convenient for patients, but it also meant you were having conversations with the practices about potential referrals, about how people were getting on in terms of progress, and those relationships allowed for that much better both transfer of information, I think improved care for patients, and really helped us deal with referrals a lot better. And I think that the ability of expanded multidisciplinary teams working with those CMHTs could make that whole process more smooth.
Yeah, definitely, for sure. And likewise, I remember the coffee conversations, which are often the most important ones. Thinking about access and demand, again, a busy section in the chat bar has been around what we're seeing more of, and the inevitable waiting times for so many people, particularly around what we're seeing, the sharp rise in increased referrals for ADHD, particularly in adults, whilst we're really struggling to kind of work out children as well. And Alistair and Gordon, actually, I'm interested in both of your takes on this. How do we manage this, and how do we support people who are waiting to wait well?
Yeah, it's certainly something that we need to really do some research on as to why this has happened, looking back, because this increase is really very dramatic over the last 5 to 10 years, particularly around the adult ADHD and other neurodevelopmental work. Within the mental health and wellbeing strategy and the delivery plan that we're producing, which should come out the sort of end of October, maybe early November, we're looking at very much as a priority about the development of a pathway for neurodevelopmental disorders. There's work that's been done with the National Autism Implementation Team to start to pilot some of this. There's something about clinical where necessary, but actually a lot of the time for neurodiversity and neurodevelopmental disorders, then actually the requirement is a non-clinical requirement. It's about support, it's about advice, it's about helping engage. So trying to make sure that we don't just automatically assume that this has to be a clinical response, and provide that where it's necessary. But so that's where we need to go with these pathways. It will take time, and this is a new thing. And again, I would argue the resources in the system are not adequate just to redesign in order to deal with this. There will be a need for additional resource in order to provide good services. But we need to do some more scoping work to work out exactly what those should look like first.
Yeah, absolutely. And Gordon, thinking about people who are having to wait long times to be seen, what can we do more to support them?
I think that the notion of tiered services is, I mean, as Alistair says, not everyone needs the specialist care. There's something about the fact that we have built an incredibly complex health and social care system, and a lot of people find the frustration of being in the wrong part of it, or being in one part and being referred to another, or sometimes even being on a waiting list to get on a waiting list for a specialist service. So I think the more we can bring people together, the easier it becomes to get people to the right place in the first place, so that rather than always thinking about referral onwards, we're thinking about, well, what services here and now can we give people that helps? And I would bring third sector into that as well. I think the point's been made a couple of times in the chat already that, you know, rather than multidisciplinary teams, we should also be thinking about multi-sectorial teams. And there are many good third sector peer support, self-help group services that can be very helpful for people while they are waiting for a specialist service, or sometimes indeed instead of that specialist service. So simple as it is to say, but difficult to do, I know, if we can get people to the right part of the system in the first place and become more efficient, then we get a better service, and ultimately we get a cheaper and more efficient service as well.
Yeah, for sure. Wouldn't it be a great topic, you know, if practices could find the time during perhaps a PLT, you know, to really just say, let's have a day on mental health. Let's invite our local teams along. Let's sit down together and think about what matters to us in our cluster. What data would help us? How could we really think about it? But as you've absolutely nailed, Gordon, that importance of recognising what else is out there, you know, particularly in areas of significant deprivation, you know, there's only about 20% of what we do as healthcare will influence people's health and well-being. So much of it depends on housing, on relationships, on jobs, on, you know, what's happening in people's lives, and that ability to tap into local community supports and assets is something I don't think we do well enough in the health sector part of things. And you know, multidisciplinary team working is not just about primary and secondary care. It's absolutely not. The other two quadrants that are equally more important, I would argue, are around our social work and social care services, and that fourth quadrant, the third sector. So what are you doing in your area you know, to really draw them in and think about how you support mental health and well-being in your local area? And just before we move on to our next topic, again, a plea in recognising that MDT. I was very late in my career before I realised that occupational therapists are dual trained in mental health and are actually very often some of the best MDT members to really come in that early intervention and proactive care and support. So I will leave that with you as my little nugget of learning to pass on to anybody who didn't know that today, or maybe I'm just showing myself up. Anyway, I think it's time for me to move on to our second part of the session and to introduce Scott, who's going to facilitate it. Keep the chat bar going, but it's brilliant today. So thank you very much, everybody. Over to you, Scott.
Thanks so much, Michelle. It's great to be here again. And yeah, Scott Jameson, I'm a GP, and here from the RCGP. It's great to co-host this. And what an amazing day! It's great to see so much chat in the going on in the chat bar there, and so many people attending today to keep us on our toes. This section we are going to be looking at the practical sides of how actually are we implementing those strategies that were alluded to by Alistair, by Gordon, by Kirsten, and look at how we actually implement in practical examples and successes and challenges, and how do you actually deliver something which is great. Absolutely. Michelle, as you allude to, I think the Michael Marmot phrase would be, why treat a person and send them back to the conditions which caused them to attend you in the first place? And so the great work of our community link workers, social prescribers, and such like to integrate with our mental health support and our practices to reduce that. And absolutely that multidisciplinary teams. I saw a name statement. We were working on our primary care vision strategy, vision and strategy earlier this week in Tayside, and we wondered if multidisciplinary was too medical, and maybe we should say teams more often, and examples of team working so that we can be really, really inclusive, because we need to make sure that that absolutely includes our social care and our third sector, and that absolutely in the widest sense, because we're all part of that team. And talking of teams and looking at how they're doing it, it's great to, first of all, I'm going to do one, and then they can just hand one to the next person. Initially, we're going to have Karen Darrick, who's the Integrated Service Manager in Midlothian, who's going to talk about the work that they've been doing there, and a bit more closer to home for myself. It's going to be great to hear from Gail Forrest and James Kennedy, who are from my part of the world, from Angus Health and Social Care Partnership, where I'm the clinical director. I'll declare my interest. But it's going to be great to hear the work that they've been doing up in North Angus about a mental health hub approach. How does that work, and how is it helping our patients? So it's going to be amazing to hear from them both. And first of all, Karen, over to yourself. Thanks so much. Keep the chat going, guys. Thank you. Oh, Karen, you're still muted.
Oh, sorry about that. Good afternoon, everyone. My name's Karen Darrick. I'm the Integrated Service Manager for Mental Health 18+, which includes primary care and the substance use services here in Midlothian Health and Social Care Partnership. So today I am going to give you an overview, if we could go to slide 2, in regards to the why, the how, and what we decided to do here in Midlothian in relation to addressing the primary care model. To next slide. My slides aren't showing, just to make you aware. Will I just keep going?
Yes.
We can see them. Yeah.
Right, no bother, that's perfect. Because I just don't want to lose my place, sorry. So moving on, so I'm sorry if I'm going over familiar grounds with you, but obviously here in Midlothian, as part of the mental health strategy, we wanted to set out our vision of how we would address multidisciplinary team, wider team working within general practice, and part of that was the vision of early intervention, prevention, and enabling people to get the right access to the right person at the right time. And part of our development of our model was very much incorporating the Action 15 element of the strategy about increasing the mental health workforce within general practice and trying to achieve a vision of improving that access. So moving on to the next slide, this also complemented the primary care transformation, whereas again, very much so, it was about creating multidisciplinary team professionals working in the heart of the community through general practice. So how did we do this? So basically in Midlothian, the primary care mental health team was established in 2017 as part of the strategy. Midlothian has 12 GP practices across, and there was nurses. We decided to go with a model where we would employ mental health nurses, and across that they would be aligned to each of the GP surgeries. We designed to provide patients with a direct and timely access to triage assessment and brief low intensity evidence-based interventions, patients presenting with mild to moderate mental health difficulties. Again, it was about improving access to the service, reducing barriers, and basically to improve the individual's journey to flow through the continuum from primary care to secondary care and back again to primary care, depending on that person's needs. The team was largely funded by Action 15 with a contribution from the Primary Care Improvement Fund. So the next slide will show you the team structure that we had. We also developed the role within occupational therapy as time went on, and embedded an occupational therapist to work within the team, who initially we set out a model that the occupational therapist, as there was only one, would work from one GP surgery. But as time went on, what we've done is we're remodeling that, because obviously that benefits one GP surgery, but we've kind of reviewed that and decided that we're going to go with a slightly different model so that there's access to the 12 GP surgeries across Midlothian. You will also see that it is quite a small resource. We have one team manager at full-time weight, an 8.8 weight of nursing, and one occupational therapist across the 12 GP surgeries. So what have we done to integrate the community mental health team and the primary care MDT? So in Midlothian, just to give a little background, we have a recovery hub in Midlothian, which has been established since 2019. And within this integrated building, we have adult mental health, substance use, justice. We also have our third sector, peers and hosted services. And our hosted services could be services such as our sexual health, welfare, advocacy, carers and peer support, which also primary care can have access to also. The team manager sits within the administrators based here at number 11, so they have that visible presence and that point of liaison that they can have with the community mental health team. The team manager also represents the primary care team at the multidisciplinary sector meetings, and it's at this point where we can discuss referrals, share referrals, and there's that seamless transfer without the patient being involved in it. So all the background work gets done with us, and the patient doesn't have to be involved in that process. The primary care staff have direct access for advice and support via telephone or email to the consultant psychiatrists that are delegated to the patches within Midlothian in regards to the GP practices. And the secondary care staff have clinics, as someone identified earlier in the talk, that we do have secondary care staff that go out and work from some, not all, but some of the GP practices, and that could either be the consultants or the CMHT community mental health nurses or occupational therapists. So the members of the CMHT attend meetings as guest speakers to the primary care team. Again, this is very much a positive aspect where it identifies things where we can address any concerns or issues, also looking at roles and remits and building a really good understanding between both primary care and secondary care. The GPs also have their huddles, and again, the primary care staff that work within the GP practices are very much part of that multi-agency team that works within general practice, and they spend, time with each other, getting to know each other's roles and having those what you call like corridor conversations when there's, trying to iron out things that are needing to be addressed. We also have improved on our multi-agency meetings and also being clear about our shared care arrangements. Moving to the next slide. So what we've learned from our process is that what we've identified is that we feel that it has improved access and it's reduced barriers for people accessing mental health services, individuals having access to the right care to meet their needs, mental health specialists working in the heart of the community, It has absolutely improved relationships across the wider teams, improving communication and smoothing out the patient's journey and care provision. It's improved collaborative working through multi-agency discussions and meetings and shared care. There's opportunities for us all to share experiences in knowledge and training and development, and education sessions have been implemented delivering on primary care transformation. What we've learned from this process in regards to our barriers, obviously the demand outweighs the capacity, and we learnt that very quickly after the primary care team was put in place. The primary care team, in regards to resource and finances, as you saw earlier, we only have 8.8 mental health nurses across the 12 GP practices, and that's one thing that the GPs highlight all the time. Though it's great to have the primary care nurses and the occupational therapists within our service and having access to them, but there's not enough of that, and that's very much something that we've learned very quickly. Obviously, COVID-19 had a significant impact on primary care and general practice, where most went to working from home. So now we're in the process of rebuilding that and rebuilding our relationships again. So it's very unfortunate, you know, for us all that COVID-19 happened, and the impact that it had not only on the services but also in the relationship, the strong relationships that were being built in primary care. But I'm pleased to say that that's improving. We also have environmental issues. As you know, we build buildings, etc., for the workforce that we have at the time. But as we know, services are expanding, they're getting bigger, and now one of the issues that we've identified in Midlothian is now that we have a wider workforce, which is fantastic, but we can't all squeeze them into the same building at the same time. Obviously, IT systems is a massive issue, because obviously within here in Midlothian we have 2 GP systems, but we also have NHS Lothian system as well, and it's about coordinating that as a one system. The workforce, obviously the workforce is around the financial cross cover. That's one thing that obviously is a barrier in a sense, because of our current workforce. It doesn't enable us to be able to, if someone goes off absent or on leave, we can't cross cover that. So that means that when there's a mental health professional not at work, then that GP practice does not have that support from a specialist mental health professional. And obviously finance and recruitment. And as we know, there is a workforce pressure, especially across all disciplines. Actually, there's a workforce pressure in regards to that. So one of the things I should have highlighted is obviously as part of our model, we are an 18 to 65, and we identify that there is a gap for our older adult population, 65 plus, and that is something that we are looking at and addressing, and how that could be embedded within the primary care team that we have at the moment. But again, that's increased demand that will be put upon that, and at the moment we don't have the workforce to be able to take that on. Moving to the next slide. So how will we overcome some of our issues? So obviously the team manager works very closely with the secondary care colleagues to promote that relationship and multidisciplinary team working across primary care and secondary care services. And obviously at the moment, due to the other issues around environmental workforce, we have a flexible working model between the primary care staff working from home and also working within the practice environment. Next slide is obviously in relation to looking at the kind of impact. What we've identified since having the primary care mental health nurses, we've seen a decrease in mental health the patients being booked into the GPs, although this is on the increase in the demand, so there is that flex, and we can continue to review that. There's 37.25 days in clinical practice provided by the team to the GP practices. So we have an 11-session model where there is 6 triage appointments provided each day and 5 follow-ups provided. And obviously part of that is 195 triage appointments a week offered and 167 follow-up appointments offered each week in regards to our capacity. We've got improved collaboration working across primary care and secondary care, because it's improving patients' pathways and communication. although there's an increased demand out there, we do recognise that access has improved and there is reduced barriers. There's positive outcomes for individuals across the spectrum, both in primary care and secondary care. So in relation to the generalised feedback that we've got, the feedback on the service is generally very positive by patients and the key stakeholders. The service is considered to be invaluable to offer value to GP practice and to the patients, improving access to the right support at the right time. And the patient's feedback tends to be more verbal and rather than written, but different. They are recognising the difference, having access to a primary care mental health professional within their GP practice. Next slide. So the next slide just gives you a kind of little brief scoping of a sample of feedback that we've received both from GPs and patients. So I'll let you read that over. Moving on to the next slide. So what's next for us here in Midlothian? So we're now looking at and addressing any opportunities to enhance the primary care arm of the mental health services, as we all recognise it's an extremely valued element within general practice. We are also needing to look at our data collection, because obviously we have 3 systems that we work from, and it's about being able to pull the right information to show value and evidence, you know, the really good work that the primary care mental health team is doing with the wider multidisciplinary team in general practice. We're also going to look at ways to improve our patient feedback. Obviously, one of the barriers is because of the blended model that we have at the moment from working from home and working within the practice. We're trying to look at ways that we can actually develop a tool that will enable us to capture that in a better way. And then obviously we have our core group established to continually review our current pathways and always looking to enhance and collaborate in partnership across the spectrum to improve our delivery and multidisciplinary working across both primary care and secondary care. And that's me come to an end. Thank you.
Yeah, Gail, do you want to just kick off?
I'm gonna. I think James is on now, so yeah,
Oh,
he's gonna
James is
do
up
the
first,
first
yeah.
lot, and then I'll come in after that.
Yep. Okay. So I suppose adding on to what everybody has already kind of said, and I suppose addressing some of the earlier barriers that had been mentioned about access to services, about working closely with kind of third-party sectors, addressing waiting times. And one of the things that we established 2.5 years ago was an enhanced community support mental health hub based in the largest practice in the Northeast, which covers 3 GP practices in the Links Health Centre, where our hub's actually based. A lot of the kind of work that we kind of looked at was based around those kind of some of the national drivers that can be mentioned, such as the mental health strategy of looking at about early intervention and prevention, about kind of better access to treatment, joined up working with services, about actually improving arrangements for people with dual diagnosis, with substance misuse, mental health diagnosis, and that kind of fits into the current kind of MAT standards around standard 9, 3 and 6 around better access to mental health, better access to kind of anticipatory care and psychological support, but also with a recognition of some of the other drivers about that those most at risk of harm, poverty, drugs, violence will also have the greater risks of poor mental health. And the current kind of mental health and wellbeing, the draft strategy kind of looking at that whole population approach about actually improving the mental health of the population and actually kind of addressing those needs of those at higher risk of kind of developing mental ill health. So although that was based on national drivers, within locally we really looked at kind of what had been going on. And prior to the development of the hub, I had worked closely with the GPs for 3.5 years. And what we saw was that really, if you sat at that higher level, yes, you got access to services. If you sat at a very low level, you got access to something. But a lot of people sat in between, in the middle, that weren't getting access to anything. And I suppose that was a role that the wellbeing role had done. But then it was kind of clear that they wanted to move away from that, and they put in peer workers. And which I've always supported that, but actually within that kind of that world that initially was saying, hold on, we've gone from a professional to getting a volunteer, which was very not the case, but it was that, hold on, things have shifted. What we were aware of is, as was already mentioned, rejected referrals, people not quite fitting into that criteria, or as we've seen because of the kind of problems that we have with services and the capacity, people being scrutinised and felt so much more that people were getting rejected. What we're aware of, obviously, with GPs often weren't aware that those referrals were rejected because of maybe how they came in via letter or electronically just put into the system. But more importantly, the patient wasn't aware. So 3 months later, the patient turns up back to GP and says, I haven't heard anything, re-referral, here we go again, denying that patient that access that they vitally need. So that kind of whole missing those kind of the opportunity to do that early intervention and prevention. We were also aware that those with a dual diagnosis in particular were often past pillar to post. They're not for us, they're for mental health, no, they're for substance misuse. And that whole bandying about, again, delaying treatment. What was very evident, because we had worked in that kind of primary care setting, we were fully aware of the waiting list. So we were aware that potential, say, psychology or counselling, you could wait up to 4 months. But at that time, there wasn't those alternatives. So could we offer something differently rather than having people waiting and waiting? And I think that is something that kind of model has done. Next slide, please. So the hub is a kind of an enhanced support. It is delivered by community mental health teams. It's delivered by our Angus Integrated Drug and Alcohol Services, our psychological services, but also a key partner is our third sector, and that third sector is run by peer support workers from both Hillcrest and Penumbra. And that was really essential at the very beginning, that we very much see ourselves as equal partners. No person, no organisation is better than anybody else. And I think one of the things I've heard is about multidisciplinary team. I would say we describe ourselves as a mental health family, and that is how much we took that approach as being a mental health family. And one of the benefits of having us all together was learning, understanding people's roles, understanding what people accepted, didn't accept, being able to have those really positive conversations about getting to know each other and getting to know each other and how everybody ticked. So that was a real key part of that kind of that model that we wanted to put in place. Next slide, please. So what we wanted, and what we did was, I suppose, in terms of that project aims, and I'll come to the process in a minute of how we went about this, but we wanted a clear process. We wanted a one entry route. We were aware of multiple entries of trying to get people seen. And so what was very clear from our partners was that they wanted a single point of entry. And that was really important, that the referrals came into that one place. So it didn't matter how it came in from GP land to us, it came in that one way. And what we will see is, however, we made it much easier for patients to be able to access that. So that resulted in the kind of quicker referral to treatment because we had that discussion. It was really about all agencies working together. We wanted to kind of promote that real kind of togetherness of actually looking at that patient as not only as an individual, but also recognising that many referrals are multifaceted. They're not single. There's lots of things that the reason that referral come in: mental health, substance misuse, financial issues, homeless issues. And rather than having 4 separate referrals for that, actually one referral that could be done by a group, as in the hub, that can actually manage that all together. So that was avoiding the whole duplication. There wasn't the multiple referrals need to be going all over the place. It made the transition of care better, and it was coordinated better. What was very, very key and very clear from the outset is we did not want any referral to be rejected, and all partners from our GPs right the way through were very clear. We wanted that we wanted to be able to offer people services straight away. And so at this time, so I'm 2.5 years in, we have had 3,000 referrals. Not a single referral has been rejected, and every single person has been offered the service. Sometimes that will come back and I'll explain that, but actually what we're making sure is that we're not getting people saying you're not for us, or you need to go somewhere else, and you've got to find somewhere that you might have to go and shoot something for you. But obviously those referrals are tracked, we're aware of the outcomes, we're aware of what's happened, and that then helps us to develop that. Since the outset 2.5 years ago, we have not had to change this model. We are doing exactly the same that we did 2.5 years ago. And I think that's testament, because a lot of improvement projects, you end up tweaking and changing, and actually you get away from what you wanted to do in the first place. And that is the case as we've moved on, as Gail will probably talk about in our further developments. Next slide, please. So the process, and I think the key thing about that process was really that we when we first got together, we kind of looked at all our partners, so GPs, all the agencies involved got, and it took us 6 months before we even started this whole project. So that whole bit of get it right before we started is some of the things I've mentioned. So we meet every day. We meet at 10 o'clock every day. Not all agencies come every day, because we didn't want it that it became onerous for them. So we wanted to recognise that, for example, community mental health teams and the peer support would take the vast majority of referrals that come in, and less so with the psychology and the substance misuse. So CMHTs and peers would meet every day, but there are other partners like our drug and alcohol 3 days, and a psychology, so that we weren't taken away from clinical time, that actually there was clinical time that you know, we weren't taken away from that. It is majority is face to face, but for some of our psychology colleagues, we sometimes make that as a, you know, a Teams thing, just so they can still join. So as we said, there's no rejected referrals. It's a single point of access. But most importantly, we accept self-referrals, so the patient can self-refer to the hub, and they can either do that as a paper copy, or they can send it to a generic email address. So those referrals they can be very basic, to just, I need help, I am anxious, to we have had some exceptionally amazing referrals that are so detailed that actually services such as psychology have just accepted that. And I think that is a shift from where we would have seen a professional needs to put a referral in just to get accepted. So the fact that we've been able to do that, we make the decisions on the day for every referral, and we will electronically send a message back to the GP to say, this is what's happened, this is what's happened to this referral, thank you very much. So they're aware. So if the patient should come in, the GP is aware. There's no re-referrals, because if a referral has gone to, say, a peer worker, the peer worker has saw that person and they think, I think they need more, they bring that back into the hub, and we will deal with that ourselves. And if it is a multi-agency or a comorbidity, we deal that. One of the biggest fundamental changes are joint working with our drug and alcohol colleagues, where every single referral comes in where it's seen that, we will arrange to see that person jointly, and within the timescale of our ADAS colleagues of 3 weeks.
Thanks, James. I'm going to cut in because we've got to cut off at 2 minutes past. So okay. I've got to go and do my, no pressure, go and do all my slides in the next bit. So implementation in the Northeast, it took 6 months, and the key areas for success are that we had a clear project and action plan, steering group with key stakeholders, regular steering group meetings, and the main thing to say is that we've established this with no funding and no extra resource. This has all been done within the teams that we currently have. Next slide, please. So evaluation happened. We had an initial 6-month evaluation of the Northeast Hub with the team, referrers and patients. We then went on to an ongoing evaluation 6 weekly by the project steering group to make sure we were on track. And then that was followed by an annual review. That basically came with no change to the initial test of change. Next slide, please. These are the benefits, shared knowledge. These are all things that have been said earlier. One referral for GPs, patients not telling their story multiple times, co-located with GP surgeries, no financial implications, more than 3,000 referrals, and as James says, with no rejected referrals. Barriers, Karen kind of covered a bit of this as well. Premises is an issue. We want to be located within GP surgeries. That's not possible right across the board, but we're working on that. The dedicated admin support is something that we definitely need, because it's brought in a lot of work for admin. But overall, next slide, please. Next steps, 6 months review of the Northwest Hub, which is where we've rolled out to from the Northeast. So Northwest started in February, which Scott is part of. We will then roll out to the south of Angus before the end of 2023. We will bring in distress brief intervention. We've got self-harm and MIIUs coming on board, and we want to obviously think about the cost of living and how we bring maybe referrals in from those people into the hub as well. That's a complete whistle-stop tour. Apologies, but if anybody else wants anything, if you go on to the next slide, you have all our details from James and myself, and we would be more than happy to go in and give you some further information.
Gail, thanks so much. You guys did amazingly at the end there. Yeah, closing remarks from Adeline. Thank you so much from our perspective. Adeline, hand over to you.
Thank you. Apologies for running over, but I just want to say thank you so much to all the speakers who have contributed to today's session, as well as to our planning team from RCGP, Scottish Government and NES, who will produce this series of webinars. And thank you to my fabulous organizing team who have put in so much effort to put this webinar off. You will see that there is an evaluation link posted in the chat box. I know we have run over, but we would be so grateful if you could complete this and let us know what you took away from today's session and how we can improve these webinars. We are also always looking for suggestions for future webinar topics. So if you have any other suggestions for topics or speakers, please let us know through the evaluation link. The recording and slides as well as the resources used in this webinar will be uploaded to our website and circulated to everybody who's registered. Our next webinar, webinar 13, will take place around end October or early November, and the dates still to be confirmed. The topic is respiratory care and management in primary care. We will shortly inform people on our mailing list when registration opens. Next slide. So the last one we want to mention is our primary care improvement portfolio. I'm delighted to host Achieving Diagnostic Excellence in Primary Care webinar. This is part of the wider SPSP National Learning Event, Creating the Conditions for Safe Care. It takes place on the 20th of September at 2 p.m. It's a virtual webinar and it will be led by Professor Hardip Singh. He will join us from Houston, Texas, to discuss how we identify and understand diagnostic errors and their contributing factors in clinical practice and solutions, including how clinicians can learn from diagnostic errors and interventions to achieve diagnostic excellence. You will then have an opportunity to contribute to an exploration of key issues and priorities for patient safety in primary care in Scotland. So all the information is on the QR code on your screen or via the link in the chat box. If you want to attend the full day virtual event, please visit our webpage, the SPSP National Learning Event webpage. And without further ado, keep in contact with us through any forms of communication on the screen. Thank you again and this is the end of the webinar. Enjoy the rest of your day.